Welcome to MED-MYSTIFY. Alright, today we're tackling something that, let's be honest, can feel like a giant puzzle. Cardiovascular pharmacology. If you've ever stared at that massive list of anti-arrhythmic drugs and just thought, how on earth do all these work? Well, you're in exactly the right place. We're going to break down the mechanisms of action for all the classes and describe these drugs by name. Think of these medications as pharmacological traffic cops managing the heart's electrical highways.
Okay, let's dive right into this. Here's our roadmap for today. First up, the heart speed limit. Then, we'll hit the 4 classes of action, followed by a deep dive into Class 1 sodium blockers, and finally, Class 3 potassium blockers. Let's get to it.
All right, Section 1, the heart's speed limit. To fix a rogue heart rhythm, we really have to get a grip on what drives cardiac conduction speed in the first place. So to do that, we need to talk about dV by dt. I know, it sounds super technical, but stick with me. Pronounced dV by dt, this is just a mathematical way of showing the rate of change of membrane voltage, that's the V, with respect to time, the t. And this all goes down during phase 0 depolarization. Basically, this equation is just telling us how incredibly fast the membrane potential shifts when a hard cell depolarizes. It's a direct reflection of the speed of sodium-mediated depolarization. So, in short, dV by dt dictates the conduction velocity of the electrical impulses just zooming through the heart muscle. Now think of it like driving a car. If you barely tap the gas pedal, the car accelerates really slowly. That's your low acceleration, right? A low dV dt. The electrical impulse in the heart just kind of takes its time rising. But if you mash the gas pedal to the floor, bam! High acceleration, high dV dt. The electrical impulse shoots up rapidly. The whole speed of electrical conduction in your heart absolutely relies on this specific acceleration. So what's the actual medical play here? Well, it's a pretty straightforward cascade effect. Step 1. We use these anti-arrhythmic drugs to actively lower that dV/dt acceleration, which naturally leads to Step 2, slowing down the overall conduction. And when we slow things down, we hit Step 3, which is interrupting those abnormal chaotic electrical circuits, like re-entry pathways. These drugs are literally throwing down speed bumps on the cellular level to stop runaway electrical signals and get us back to a normal, healthy rhythm.
Moving right along to Section 2, 4 classes of action. Let's actually meet the pharmacological traffic cops directing this highway. Okay, quick exam tip here, guys. This mnemonic for the Vaughan-Williams Classification is an absolute lifesaver. Just think sequentially. Class 1 are sodium blockers. They slow phase 0. Class 2 are your beta blockers like metoprolol, and they slam the brakes on the SA and AV nodes by blocking sympathetic stimulation. Class 3 are potassium blockers, which prolong repolarization, and Class 4 are calcium blockers like verapamil, restricting calcium entry to specifically slow down that AV node conduction. So 1, 2, 3, 4. Sodium, beta, potassium, calcium. Boom. Easy to remember, right?
All right, Section 3, Class 1 sodium blockers. These are our membrane stabilizers. Let's see how they actually do their job.
Now within Class I, there are some really crucial nuances. We divide them up into subclasses A, B, and C, and they differ wildly in how they treat our old friend dV/dt and the action potential duration, or APD. Class IA gives us a moderate decrease in dV/dt and actually increases the APD to prevent re-entry. Class IB, it's more of a lighter touch. Just a little decrease in dV/dt, and it actually decreases the APD, which makes it awesome for ventricular arrhythmias. But get a load of Class IC. We're talking a marked, massive decrease in dV/dt with minimal change in APD. It literally hits the conduction brakes harder than any of the others.
Let's put some names to these, starting with the classic Class IA agent, quinidine sulfate. This one has a wild dual use. It's used for life-threatening ventricular arrhythmias, but get this, when you give it IV, it's also used to treat Plasmodium falciparum malaria. Crazy, right? But honestly, we rarely use it today because the side effects are just intense. It can trigger a super dangerous rhythm called torsades de pointes, immune-mediated low platelet counts or thrombocytopenia, and this bizarre toxicity syndrome called synchonism. The hallmark of that one, a constant, maddening ringing in the ears. Staying in Class IA, we've also got procainamide and disopyramide. Both are primarily used for ventricular arrhythmias and tachycardias. Disopyramide is a solid cardiac depressant, but I really want to focus on procainamide's severe risks for a second. Beyond the usual dysrhythmia and hypotension, procainamide carries a really significant chance of triggering drug-induced lupus erythematosus. That's a serious immune response that brings along absolutely terrible joint and muscle pain, arthralgia, and myalgia. Definitely something to watch out for.
Shifting gears to Class IB, let's talk about phenytoin sodium.
This drug has an incredibly unique profile. You probably know it as an anticonvulsant for managing seizures, but it actually steps in for ventricular tachycardia when a patient isn't responding to anything else. The side effects, though, are uniquely physical. Patients might experience increased hair growth, enlarged gums, and in some really severe cases, terrifying skin reactions like toxic epidermal necrolysis.
Now, what's really interesting is our next drug, lidocaine hydrochloride. You almost certainly know this one from the dentist's chair as a local anesthetic. But surprise, it's actually a prototypical Class IB antiarrhythmic. Because of its anesthetic roots, the side effect profile is, well, pretty strange. Patients can get circumoral paresthesia, which is just a fancy way of saying a tingling sensation right around the mouth, along with a distinct metallic taste, feelings of euphoria, and, ironically enough, seizures if they hit toxic levels. Rounding out Class IB, we're going to group toconide and mexaletin together. Toconide is actually a primary amine analog of lidocaine. Both of these are absolutely critical for documented, life-threatening ventricular issues, but yeah, they come with some pretty uncomfortable side effect profiles. Toconide often brings on severe vertigo, tremors, and confusion. Mexaletin, on the other hand, leans more into abdominal pain and GI issues, with rare but real risks of seizures and liver dysfunction. Okay, moving into Class IC, we have lorcanide hydrochloride. Remember, this is the class that acts like a brick wall, the marked decrease in our DV/DT speed limit. It's highly effective for restoring normal rhythm in premature ventricular contractions and Wolff-Parkinson-White syndrome, but you really have to pay attention to the delivery method here. Its central nervous system side effects, things like dizziness, terrible headaches, and sleep disturbances, are actually significantly worse when the patient takes the drug orally compared to getting it via IV.
Section 4. Class 3 potassium blockers, prolonging repolarization. These drugs act as traffic control, but instead of slowing the initial impulse, they delay the reset phase, so electrical signals can't re-enter circuits they shouldn't.
First up here is the absolute heavyweight, amiodarone. This is your primary go-to antiarrhythmic for frequently recurring, hemodynamically unstable, life-threatening ventricular fibrillation and tachycardia. Basically, it does the heavy lifting when all other therapies fail. But because it is so incredibly powerful, it comes with a massive range of systemic side effects. We're talking severe fatigue, tremors, a lack of physical coordination, decreased sex drive, and a whole host of gastrointestinal issues. And then we have sotalol. It's an ethynylamine derivative acting as a non-selective beta-adrenergic and potassium channel antagonist. We use this one mostly to maintain a normal sinus rhythm in patients dealing with atrial fibrillation or flutter. But man, you have to monitor this one incredibly closely. Over 10% of users get hit with side effects like bradycardia, a dangerously slow heart rate, and general weakness. But the most grave risk? Sotalol causes QT prolongation, which can lead right back to developing the life-threatening torsades de pointes we talked about earlier. So that leaves us with a pretty provocative question, doesn't it? How on earth can the very drugs designed to cure arrhythmias, like quinidine and sotalol, actually cause life-threatening rhythms like torsades de pointes? It perfectly illustrates the incredibly delicate pharmacological balancing act we have to play. By tweaking the heart's electrical speed limit and messing with repolarization, we are walking a razor-thin wire between managing chaotic heart rhythms and accidentally sparking brand new ones.
Understanding these mechanisms is absolutely crucial to keeping your patients on the safe side of that line. Be sure to write your questions, suggestions, and thoughts in the comments section. We will catch you in next one. Like, subscribe, and share this with your friends for such more pharmacy-related informative explainers.